Welcome to NEET PG Concepts, my dear friends. I'm your host, Dr. Shadab Jafri. Now, friends, you may recall that in the previous video we have discussed about the middle cerebral artery stroke. Now, we have told you that we'll be dealing the other strokes and in those strokes, posterior cerebral artery stroke is the one of the most important to deal. And today we'll deal with the posterior cerebral artery strokes. Now, you carefully look at this figure which I'm showing you. This figure I have previously also shown to you. This is the blood supply of the base of the brain. It's also known as circle of Willis, and this is very important. And you know that this circle of Willis is formed by, see, it is formed by, this circle is formed by the posterior cerebral artery and posterior communicating artery, the anterior cerebral artery. Now, which part of the posterior cerebral artery? You can see that the before the posterior communicating artery, which is arising from the internal carotid artery, the part which of the PCA is known as the P1 segment. After the posterior communicating artery, it is known as P2 segment. And similarly, in the anterior cerebral artery, it is the A1 segment, and after the anterior communicating artery, it is the A2 segment. So, A2 segment and P2 segment are not forming the circle of Willis. The circle of Willis is formed by the P2 segment, posterior communicating artery, A1 segment, and the anterior communicating arteries. And this concept is very important for you to understand when we further deal small vessel ischemic stroke lacunar infarction. We'll deal further. Now you carefully see in this figure that the P1 segment is forming the circle of Willis, and the P1 segment is supplying the areas of the which are the base of the at the base of the brain, the cerebrum, uh, white matter, gray matter, and the pons and medulla. So the white matter and gray matter part they are supplying. The P1 segment is supplying. And here you know that in this center there is thalamus also. So there are thalamic branches which are supplying the thalamus. So and now you see the P2 segment which is after the posterior communicating artery. Now this is supplying the occipital lobe and the temporal lobe. So this is very important for you to understand. Based on this, we'll deal the P1 and the P2 syndromes, and all of them are named. They are named syndromes, and those are very important because they can be asked in the future as a part of your MCQ. Now you see here that there are four main syndromes which are important for as a entrance exam student for you to understand, and you must have studied in your neuroanatomy classes also. Now Weber's syndrome. What is Weber's syndrome? It is the third nerve palsy with contralateral hemiplegia. Then Claude syndrome. What is it? Third nerve palsy with contralateral ataxia. Then a very important question in every entrance they are asking now contralateral hemivalismus. When the subthalamic nucleus is involved, then contralateral hemivalismus. Now, if the thalamic branches are involved, then that gives rise to Dejerny-Roussy syndrome, which is contralateral hemisensory loss with pain, deep searing pain or burning pain. Now, in this figure, you can see that P2 segment, the P2 segment has the cortical branches which are supplying the temporal lobe and the hippocampus, and which are supplying the occipital lobe. As you know, the occipital lobe is dealing with the our visual senses. It has the visual cortex and the visual association areas. Temporal lobe deals with the temporal lobe and hippocampus deal with the memory part. So when these are involved, our memory will be affected, our visual senses will be affected, uh, and you also know that the our memory uh, is mainly dealt by the dominant hemisphere, and it has a bilateral representation. So we'll deal in the later part what effects this P2 segment stroke will be having on our body. Now you see that if the distal PCA is occluded, then there will be homonymous heminopia without macular sparing. Now this without macular sparing is very important because if you see that the if the in middle cerebral artery stroke there is homonymous hemianopia with macular sparing. Now why the macula is spared in MCA stroke? Because the PCA the P2 segment is supplying the calcarine cortex, which is responsible for the central vision, macular vision. So that is spared. Now, if the medial temporal lobe and hippocampus are involved, there will be acute disturbances in memory, particularly if the dominant lobe is involved. But these usually clear because memory has bilateral representation. Now, two more important terms. Now, balance syndrome. What is balance syndrome? The bilateral involvement of distal PCA results in cortical blindness, and the patient is unaware of it and may occasionally deny it. And in this type of blindness, pupillary reaction is present. Sometimes there will be small islands of vision here and there, and the central vision will be there, and peripheral vision is lost, and that is known as gun barrel vision, which you see in these cases. So this is known as Anton syndrome. Sorry, not balance. Balance will deal later on. Balance. What is balance? Balance is a bilateral visual association area lesion. No, not the main visual area. It is the visual association area. Now, visual association area will lead to very interesting features like palinopsia. What is palinopsia? It is persistence of visual image after the visual scene has passed. Several minutes after the visual scene has passed, the patient will be seeing that image which he was seeing before. And these balance syndrome, it is seen in the low flow ischemic stroke between the watershed areas of the MC and the PCA. Now recall the figure of that circle of Willis which I have shown you previously. You can pause the video or you can go back to the video and see that figure. Now in that part I have told you what comprises the circle of Willis. Now this circle of Willis has a small penetrating branches, means the antecerebral artery A1 segment, the basal arteries, the posterior cerebral artery. So all these form the circle of Willis, and all these give the penetrating branches to the gray matter and the white matter of the cerebrum, pons, and the midbrain. And these small vessels, if they are occluded by any embolus or some lipohyalinic occlusion, thickening of the arteries, then this will lead to small vessel ischemic stroke. And these are very important. These have very interesting names, and they can be asked because each of them has its specific blood supply and its specific clinical features. Now, to name pure motor stroke means the pure motor stroke will be the corticospinal tract is involved in the internal capsule. Now, there can be a pure sensory stroke if the thalamus is involved. Now, there can be dysarthria with the clumsy hand where the ventral pons and genu of the internal capsule is involved. Or there can be an ataxic hemiparesis when the ventral pons and internal capsule are involved. So, these are the names which you can remember, and you will see in your clinical day-to-day practice. These are also the cases which we get in our regular practice.